I think we should start. Yeah. I want to welcome everybody who's joining us today in the final public lecture of Raymond de Vries as Professor of Midwifery Science aan de Academie Verloskunde Maastricht and Maastricht University. Yeah. I want to welcome everybody who's joining us today in the final public lecture. I want to welcome Raymond and Charlotte. We will probably say it many times today, but I wish you could both be here. It would have made this really a feestelijke bijeenkomst. I also want to welcome your family, and I'm sure that they are online as well. And many friends and colleagues from the USA. It's wonderful that they can join us. And finally, all colleagues and friends from the Netherlands and some of the other countries in Europe. This is truly an international meeting. Raymond, after a decade of professorship in Maastricht from 2010 to 2020, we're now saying goodbye to you. Well, at least in the role of professor, because I'm quite sure we'll keep in touch. We'll be seeing and hearing from you in the coming years as well. When you started, we were at the beginning of creating midwifery science in the Netherlands and establishing it. I remember our first meeting in the V&D in Utrecht, but also in Ann Arbor and here in Maastricht. There was a friendly man with a different perspective on midwifery care, the outsider perspective, as you like to call it. And with many ideas about how to protect and promote the knowledge and work of midwives. The outsider perspective was not just because you were a foreigner, but also because you were a sociologist and an ethicist and not a midwife. But you were definitely not a stranger to midwifery and not a stranger to maternity care in the Netherlands and to the Netherlands as a whole. And we have gained a lot of insights from you as an outside with your outsider's blick. Your guidance was very welcome, and your contribution has been enormous. With 9 successful PhDs within the midwifery domain and more coming, and many publications and successful grant proposals, we're now gaining a firm position in the academic world, giving power to the voice of the midwives. You have guided us to become critical scientists, better communicators in science. Your standard question every time we were discussing a paper we were preparing was, so what? Why should anyone want to read it? What helped us to think about, which helped us to think about our research and to reflect on the midwifery aspects of our study. And I'm especially grateful for the support and mentorship you have given to me in preparing me to succeed you. They are large shoes to step into. We're not surprised that there is a final message you want to give us in this lecture. There are challenges in Dutch midwifery care and maternity care, and you are a man with a mission. A mission that was never faded over the last decade. And it's fueled by a great passion for midwifery and everything that it stands for. We are happy to give you the stage. This goodbye will not be a perfect event. First of all, we're missing a party at the end of it. And what is an event without a party? But also, you're missing out on something you particularly liked about conferences. Observing people, watching what they respond, what they say. What is going on between the lines? I'm really sorry that's not happening today. Therefore, I will also want to ask the audience to use the chat, which you will find at the right side of your computer, and respond, give your reactions. We will not be able to include them in our discussions all the time, but I'm very sure Raymond will appreciate them and read them afterwards. But now the stage is yours to give a reflection on 10 years of midwifery science in the Netherlands and give us your wise lessons for the future. So now we will start the video with your presentation.
Thank you, Marianne. Esteemed Rector Magnificus, esteemed members of the Board of Directors of Maastricht University, colleagues, friends, and family, thank you for being here, and thank you for giving me this opportunity to deliver my farewell address after 10 great years at the university. To start, you may be wondering why I titled my talk Under Verloskundige, or in English, Among Midwives. Well, there's the obvious fact that for the last 10 years, I've been working among midwives in Maastricht, and for 25 years before that with midwives in the United States and elsewhere. But more specifically, I was inspired by two works of literature. One, a Dutch novel by W.F. Hermans called Among Professors, where he looks at the organization of the university and notes that the way the university is organized can make it very difficult to actually accomplish the mission of teaching and doing research. The second is a beautiful poem by William Butler Yeats, Among School Children, where after being among a bunch of young school children, he reflects on the passing of tradition from the elderly to the young, and ends with this beautiful line, how can we know the dancer from the dance, the tradition from the people who carry it on? And that reflects a bit of the tradition that I've been involved with midwifery. And you'll hear these themes coming through in my talk. But to start, why should we care? Why should we care about maternity care in the Netherlands? Well, maternity care in the world has a problem. In some countries, developed countries, maternity care does too much too soon. You can see here in this graph of cesarean sections, in Turkey, 1 out of every 2 babies is born surgically. In Italy, it's 1 out of 3. Too many interventions done too soon. But in other countries, maternity care systems do too little and too late. And you can see reflected here in varied rates of infant mortality, the red countries having very high rates of infant mortality because they do too little, too late. Maternity care in the Netherlands offers this sweet spot between doing too much too soon and doing too little too late. How do they do this? Well, they have a very fine working model of integrated care that separates the first line, where midwives work, primary care, from the second line, done by specialists. And it's based on the premise that every woman needs a midwife and some also need a doctor. This graph illustrates this perfectly. If we look at where Dutch women begin care in pregnancy, if you look at women expecting their first child, you can see that 87% of these women begin in the first line, mostly with midwives. For women expecting their second or later child, 86% begin in the first line. And then if something happens, the Dutch have this well-designed plan for sharing care between the first and second lines that lists all the indications that require transfer to or from or back and forth between these two lines, with 4 categories: care that can be done in the first line, care that requires consultation between the 2 lines, care that needs to be moved to the second line, and then care that needs to be moved to the clinic, but with a midwife in charge. It's all very well organized and very well designed. The obstetrics indication list is one of the fine points of Dutch maternity care. And people around the world have long admired the Dutch system. You see a French midwife here saying, "We admire and envy the Dutch system for the recognized place of the midwife as the first line of perinatal care, for skills in physiology, for all the choices it offers pregnant women." And her comments are mirrored around the world, in Australia, in Belgium, in Morocco, in the Czech Republic, in Norway, Sierra Leone, Ireland, and Malta. Just recently, we learned that UNESCO has honored the home birth system of the Netherlands by signifying it as part of the Netherlands' heritage, part of the world's heritage. Giving birth at home is now part of Dutch heritage, we learned. And we also see that this system is reflected in the reasonable use of interventions in birth. Here's a chart of cesarean section rates for several countries from 2017, and you can see the Dutch have one of the lower rates in the world for cesarean section among developed nations, while my second country, the United States, has a relatively high rate. Almost 1 in 3 babies are born by surgery. But on the other hand, are we in the Netherlands on the way to doing too much too soon? Well, I'm a little worried about this, and I have a few data to show you about this. Look at this example. Back in 1990, when I was first coming to the Netherlands, the home birth rate was 32%. Over the next 10 years, the next 20 years, the next 29 years, you can see it dropping precipitously to where it's at today, just above 12%. Also, if we look at births in the first line and in the second line, we see a continuous increase of women having their babies in the second line as opposed to the first line. You can see that starting in 2000 going to 2019. And I'm sad to say, if you look at where my professorship started, the trend really didn't turn around. Not that I expected it should have. Too much too soon? Well, here's the rest of the story of that graph I showed you just a few seconds ago. We saw that 87% of women expecting their first child start in the first line, but by time they give birth, only 18% are still in the first line. If we look at women expecting their second or further child, again, 86 start in the first line, but only 34% end there. What does this mean for the future of midwifery? Well, as part of being among midwives, I've asked my midwife colleagues to participate with me. So I have 5 midwives and 1 gynecologist who've submitted videos with thinking about different aspects of midwifery care in the Netherlands. And we're going to turn now to a recent graduate of the Academy in Maastricht, Judith Janssen, and she is going to share a bit about her thoughts of the future of midwifery in the Netherlands.
I was asked by Raymond to talk as a recently graduated midwife about the future of midwives and about what is needed to help Dutch midwifery reach its full potential. And then he asked me to answer this enormous question in about 90 seconds. I thought I would share my answer in the form of wishes for our future. It is often said that being a midwife requires knowledge from the head, the hands, and the heart. And in our Dutch midwifery system, I believe we're very well trained and also very proficient with our heads and our hands. But there's not always space nor time for the knowledge from our hearts. So going forward, as midwives, I would wish us more space and more time to simply be with women, so that we can feel every day what it truly means to be a midwife. And also for many, the reason we became a midwife in the first place. As advocates, I would also wish us the courage to stand up for making space for that hard knowledge by demanding and creating models of care that allow us to have time with women, to establish respectful, trusting, and equal relationships with them, and that allow us to offer continuity to them in all levels of care. As people, I would wish us a profound understanding of diversity, autonomy, and informed consent, so that we can then support women and families in making individual, autonomous, and informed choices about their bodies, about their pregnancies and their births. Finally, I would wish us to remember that the human part of care sits at the center of every decision. Thank you, Raymond, for being with and supporting students, midwives, and researchers for all these years, and for being such a great connector.
Wise words about the future of midwifery. Here's a few more wise words about the future. If we're thinking about fearing the future, a former president of the United States, not that one, but one before him, said this: "We did not come to fear the future, we came to shape it." Now, you know that I'm a sociologist, and when I think about how we might shape the future, I think we really need to understand what got us to this place. And I've been inspired by the words of a famous anthropologist, Cliff Geertz, who said, when you want to study other people's culture, first you need to discover who they think they are, what they think they're doing, and to what end they think they're doing it. And this is how I want to look at what I've learned in the last 10 years among midwives. I really have a simple 4-part story I want to tell you. First, I want to look at the organization of maternity care in general, and then more specifically at changes I'm seeing in the organization of maternity care in the Netherlands. And then ask the question, can science save us? Can they change the direction we're going in the Netherlands? And finally, look at ways to turn the tide and to bring us back to respecting physiological birth. So let's start with organization. And here's another colleague of mine. He was a student of mine. He's now Dr. Doug Croney, the clinical midwife. And he's going to give you an introduction to the organization of midwifery care and changes that are occurring.
My task is to outline some of the salient issues surrounding the organisation of midwifery care in the Netherlands. To most of us familiar, but to some less so. So first, let's quickly recap the division of labour within midwifery care. When reviewing something, one learns to start with the good. And so, on the whole, midwifery care in the Netherlands is good. Currently, midwifery service provision is divided into primary and secondary care. This stratification ensures that midwives are the gatekeeper to pregnancy service. Indeed, one could argue that midwives being the predominant provider of care to women in the community, delivering care at the point where it's most needed, that our service is the envy of many. Certainly, this model of service provision has served the profession and women in our care well, until recently. In the last 10 years, however, we've borne witness to a tremendous level of change. More than 2/3 of all women now birth in hospitals, but only 1/3 of midwives are employed there. At the same time, birth has become more complex and rates of intervention are rising exponentially. This means that as a profession, we must tackle some difficult questions. For example, in 2021, what is normal labour? Is it right that a woman can only birth at home if they're willing to do so without post-pain relief? Is it right in the culture of now that at their moment of most need during labour, that we transfer a woman's care and caregiver, breaking the bond of trust at a time when it's most required? And at the same time, does it make sense to say to women, we find that your pregnancy is complicated, therefore we advise you to birth in a hospital. Oh, but by the way, you might be cared for a midwife, or you might not. The hospital might have enough midwives to provide one-to-one care, but it might not. And oh, it's not universally agreed what educational level midwives need to work in hospitals, but yet we still continue, by osmosis as opposed to regulation, supported by good evidence, to absorb more and more of the tasks previously out of the scope of midwifery care. Clearly, in 2 minutes or in 200, we cannot answer these questions adequately, but addressing these issues will help us to provide a service which meets the needs of now, one which is modernised and fit for purpose and truly with women.
Dr. Croney reminds us that the organization of maternity care is not static. It changes in relation to the costs of care, to new technologies that appear, to new research that is done, to the attitudes of care receivers and caregivers, to ideas, changing ideas about risk and safety, and those sorts of things. But as we think about the changes that are coming, both in general and specifically to the Netherlands, I want you to keep in mind that the way we organize care for pregnancy and in birth will determine if we respect birth or if we bend the biology of birth. Let me give you an example of this. Some colleagues and I have done research on the timing of birth, looking at how the way care is organized affects when birth occurs. First, we looked at length of pregnancy, and we compared women giving birth at home with women giving birth in the hospital. What we discovered is this: if you look at women giving birth out of the hospital, at home and in birth centers, the modal length of pregnancy is what we'd expect it to be, 40 weeks. That's what we've assumed was a normal length of pregnancy. But when we look at women giving birth in the United States in the hospital, we discovered that the bell-shaped curve is centered on 39 weeks. So the way care is organized has actually shifted the length of pregnancy back by an entire week. What about if we look at the timing of birth by day of the week? Well, this graph tells you something very interesting. If you look at out-of-hospital births, you see that they're as likely to occur on any day as any other, about 14% every day of the week, Sunday through Saturday. But if you look at women giving birth in the hospital, you find that those births are much more likely to happen on weekdays and less likely to happen on weekend days. And that holds true not just for all hospital births, where you might say, well, surgery, induction, probably scheduled during the work week, but even if you look only at vaginal births. If we look at births by hour of the day, my colleagues and I have looked at home births and what hour of the day women give birth when they birth at home in the United States, in the Netherlands, and in England. And you find this really interesting pattern where most births occur after midnight and in the wee small hours of the morning, dropping off in the daylight hours and picking up again in the evening. The daylight hours, the working day, seems to have no effect except to make it less likely that birth would occur. But going back to the United States now, if you look at time of day of birth, you find home births, of course, follow that pattern that we saw in all three countries, but hospital births actually cluster between 7 and 5, the working time for people to be in a hospital. Clearly what's going on here is the way that we organize care is affecting the biology of birth. Now, if we compare the United States, the Netherlands, and England, you find, again, the US is most likely to force birth into those working hours. In England, it seems to be pretty even across all hours of the day. And the Dutch have a slight bump during the working day. So part 2, this first part was about maternity care in general, but I want to look more specifically now at what is moving maternity care in the Netherlands away from its emphasis on physiology. And I call these the big three factors. One is the way midwife practices are organized. 2 is challenges to the obstetric indications list that I described earlier. And 3 is the coming of so-called integrated care. So let's start with the organization of midwifery practices. One thing that strikes you if you look at how midwifery has changed in the way it organizes itself over the last 30 years is this graph. Back in 1980, well, that's 40 years ago, 82% of all midwives worked in solo practices. By 2018, that number had dropped from 80 to 10%. Not surprisingly, on the other end, in 1980, only 3.5% of midwives worked in group practices. That's 3 or more midwives. But by 2018, that number was 73%. Now, there's reasons for this, and I understand that, but we also know that when midwifery is done in group practices, it affects the level of intervention and satisfaction with care. One of my former students, now professor of midwifery in Belgium, did this research many years ago and concluded that when midwifery practices have a maximum of 2 midwives, there's less likely to be intervention and more likely to have a positive birth experience. More recently, a colleague of mine in Maastricht, Dr. Pien Offerhaus, also a midwife, has done research on caseload midwifery and shown the effect of that on outcomes of care. I'll let her explain.
Hello to you all. It's a pleasure to talk to you on behalf of our dearest Professor Raymond about an old but new phenomenon in the Netherlands, caseload midwifery. A small group of midwives reintroduced caseload midwifery in the Netherlands at a time when most midwives were working in groups and where there was a call for closer multidisciplinary collaboration in the form of so-called integrated care with the hospital. In this picture, you see one of these midwives, surrounded by a crowd of babies whose birth she attended. This development inspired us to investigate the motivation of these midwives and the results of their care. Caseload midwives provide one-to-one continuity of care, and they stay involved in the care in case of a referral for some medical reasons or for an obstetrical intervention. For most of these midwives, this is a reaction to the fragmentation of care common in busy group midwifery practices. Caseload midwives describe themselves as advocates of physiological childbirth, although the autonomy of women is the main focus in their care. Here we see the outcomes of their care compared to the care in regular practices. Fewer referrals, more spontaneous start of labor instead of induction, and more spontaneous vaginal birth. And more home birth, which reflects the specific group of women that choose for their care. Caseload midwives hold up a mirror to the midwifery community in the Netherlands. Let this woman-centered care be an inspiration for all the organizational changes being considered in the Netherlands and elsewhere. Thank you.
Again, we see in the work of Dr. Offerhaus how the way we organize care affects the outcomes of care and the process of birth. The second of the big three that's changing maternity care in the Netherlands is challenges to the obstetric indications list. I've talked about this before, but I want to emphasize that the obstetric indications list, last published nearly 20 years ago, was a document that was developed mutually agreed upon by all the professions involved in maternity care, and it applied at a national level. And if you look at what it said, you can see it clearly emphasized protecting physiological birth. The starting points are that pregnancy, delivery, and the postpartum period are physiological processes, and birth and the postpartum period can take place at home. This means that the normal course of pregnancy, birth, and postpartum belong under the care of a primary care provider. And I want to emphasize again, this was a nationally accepted approach to thinking about how cooperation would go between the first and second lines. More recently, however, the obstetric indication list has been bumped aside by what's called the Zorgstandaard, Integrale Geboortezorg, or for integrated birth care. And this is a significant change. This was published, most recent version in about a year ago in May 2020. And this is the takeaway line. In the future, the obstetric indications list will be gradually transformed by the professional groups involved, where the multidisciplinary guidelines will serve as the basis for care pathways at the local level. Remember this now, the obstetric indications list was a national document, and midwives who were in debate with their colleagues in gynecology could point to this list and say, look, this is what we agreed on. But now that's moving to the side, and midwives are working in teams, and they have to negotiate in the teams without the benefit of that list. The third of the big three that's changing maternity care in the Netherlands is the coming of so-called integrated care, which I think was created with the best of intentions, but it's sociologically naive. What's happening is team care is being defined as integrated care. And I see that as changing this idea that every woman needs a midwife and some need a doctor, with the idea that every woman needs a maternity care team. And that's a significant change. And to my way of thinking, that's throwing the baby out with the bathwater. Listen to my colleague, this is a gynecologist, Professor Dr. Siko Sersian, talk about integrated care.
When opening a book, lastly, a newspaper article from the early 1980s fell out of the book. And it was an article written by the secretary of the NOV, the Dutch Society for Midwifery, where Mrs. van Doren stated that the insurance system as it was designed in 1941, prioritizing the midwives in their care, should not be abandoned, but in a certain way should be strengthened to try in the 1980s to demedicalize obstetrical care. And this prioritization of midwifery care over general practitioners, and the general practitioners did quite a lot of obstetrical care before the 1980s. So prioritizing the midwives should help to demedicalize it and keep normal birth in the scope and in the hands of the midwives. I think nowadays we see a little bit the same, but it's not the general practitioners who medicalize birth, but it's in the hospitals. And the increase in hospitalization, and especially the enormous increase in inductions of labor, it's good to realize that the Netherlands is one of the countries with the highest induction percentage. This medicalization of birth, in a certain way, is again a moment to reconcile the role of midwives in obstetrical care. And it's not only the role at the home delivery, but also at the hospitals. I think it's important that the regulation and possibly also the insurance companies should be aware that the role of midwives is crucial in demedicalization. And I think the only way out is that we realize that midwives, as doctors, are both a medical profession in the Netherlands by law, and that midwives have the opportunity to take medical care and to play a central role also in the hospitals to keep labor as normal as possible. And the only way out is education. So that midwives are educated in such a way that they are real companions to doctors, that they operate at the same level as doctors, that they have the same scientific background as doctors, and I think it's crucial that they are trained at an academic level. So before we decide to get the walls between obstetricians and midwives who partitionize their care, before we decide to get these walls away, I think it's crucial that midwives and doctors have the same equal position in medical care around normal delivery.
You can see that Professor Sertian is concerned about this idea of taking away the division between the first and second line and making them one team. And he's afraid that that will result in more medicalization of birth, which indeed is what we're seeing in the Netherlands. And this brings me to what I call the fallacy of geen doel op zich, or in English, the fallacy of not an end in itself. In my 10 years working as professor, I often heard this line: thuisbevalling is geen doel op zich. Home birth is not a goal in and of itself. I've also heard it used other ways, like preserving midwifery is not an end in and of itself. Limiting interventions in birth, not an end in and of itself. All of these lack a sociological understanding of how organizations work. Let me tell you what I mean, give you a couple examples from the Netherlands. Look at this research, again, from my colleague Pien Offerhaus, who we heard from before. She looked at intrapartum, that is during labor, referral rates from the first line to the second line, and noticed for first-time moms and later-time moms, those rates were going up. And you can see that change between 2000 and 2008. But what she also noticed is that the interventions were not going up in parallel to that. So now this can make you think two different things. Are midwives referring too quickly because they're sending women to the hospital and we don't see any further need for interventions? Or are obstetrician gynecologists being very conservative in treating these women? Another example is one I've already used. Here's the normal curve of birth when it's done at home. And if you look at births in the hospital that are only vaginal births in the Netherlands, you find that hospital births more or less follow that pattern. And I want to assert why. Because the Netherlands has a model of home birth that makes people in the hospital think about physiology and think about what's possible. There are also midwives working in the hospital, which make obstetricians become more conservative. So yes, home birth is a doel op zich. It is an end in itself because it protects physiology. So change is coming. I've tried to prove that. Can we turn the tide? That's the question. Now, many people say science can save us. I've asked my colleague, Prof.dr. de Vries, to talk a bit about science and midwifery science.
We know so much about ever smaller risks in pregnancy and birth. Many studies have been conducted into how to prepare the cervix for labor, when to augment labor with oxytocin, and how long a woman should push before we assist her with a vacuum birth. But what do we know about how we can help a woman feel confident in labor, so that her fight or flight response decreases and her natural oxytocin can do its work? How much do we really know about what kind of support works for each individual woman in every labor situation? We know much more about the technical things we do than about the kind of support we give. This supportive midwifery care is still largely based on experience, tradition, and culture. We need science to make this care visible so that we can measure and evaluate it, examine what works and what doesn't, and to make sure that all women receive this midwifery care to the highest standard. Dear Raymond, thank you so much for helping to kickstart midwifery science in the Netherlands, together with your colleagues in Maastricht. You are as versatile as midwifery itself. When I think of you, I think of an American and a Dutch. I think of a social scientist and a midwife. Surely, if you have come all the way from the US because you felt it was important to help build midwifery research in this country, I don't have to say anything else about the importance of science to our profession and most importantly to women and their families.
And it is true that midwifery science has really grown in the Netherlands. We now have 4 Dutch midwives who are professors, 2 in the Netherlands, 1 in the UK, and 1 in Belgium. And these midwifery scientists are making a difference. They're asking questions oriented to physiological birth and to midwifery and not just to obstetric science. But, there's always a but, science is also a social product. Extra scientific factors determine things like what gets studied in the first place, as Anke pointed to, how research is designed, how the findings of research get interpreted, where those findings are reported, how those findings are taken up by the media, and in turn, how findings affect policies. We know that facts are stubborn. People say that facts are stubborn. You can't fight with facts, but people are more stubborn, as we've learned recently in our country. Facts don't necessarily change people's minds. And it's not just Trump supporters. I want to tell you a quick story about science in the Netherlands, showing you the social influence on research and the results of research. This study, published in the British Medical Journal, was a key turning point in policy about maternity care in the Netherlands. Published in 2010, it looked at the difference in mortality between women being cared for by midwives of primary care and midwives of higher risk being cared for by gynecologists. And as you can see, their conclusion, infants of pregnant women at low risk whose labor started in primary care under the supervision of a midwife had a higher risk of delivery-related perinatal death, compared to pregnant women at a high risk in secondary care under the supervision of an obstetrician. Completely opposite to what you would have expected, and it dropped like a bombshell in the Netherlands. Now, some Dutch researchers, some midwifery scientists, wondered about the quality of that research. And there were some problems with the fact that the database used for the denominator was not the same as the numerator and how start of labor was defined. So they redid the research in Amsterdam. The previous study was done in Utrecht. And they were much more careful about the way they used their data and the way they defined things. And in redoing the study, they came to a completely different conclusion. A low absolute risk of intrapartum and neonatal mortality, comparable for primary versus secondary care, and interventions for women in primary care were much lower. That was published 5 years later. And then part of that group, gynecologists, obstetricians, were not really happy with that conclusion. So they reanalyzed the data, published that data 3 years later in BMJ Open, not quite the same as BMJ. And they came to this kind of interesting conclusion. It almost amuses me. Among low-risk women, midwife-led care at the onset of labor was associated with a statistically non-significant higher mortality rate, which means it was an artifact, which means it wouldn't apply to a larger population. Nevertheless, they published this study. Now, what's interesting to me is where were these studies published? So the first study, the one that made such a difference, was published in a very important, well-known journal with an impact factor of 30.2. Now, an impact factor measures how often the journal gets cited, how often it gets read, meaning it's going to make a difference in the world of science. So that first study that said the Dutch system is not working well, done by gynecologists, was published there. The second study, showing the Dutch system is working exactly as it was designed, was published in the journal Midwifery with an impact factor of 1.7, much less. A great journal, but mostly read by midwives. And the third study, with that idea that the Dutch system is questionable, done by gynecologists, was published in BMJ Open with an impact factor of 2.4. So you see where research ends up and where it is likely to get published is really important. Maybe more important is how the media picks up these studies. And you see here that first study done in 2010, as I said, made a big splash in the Netherlands, getting the first page on NRC Next, don't try this at home, making such a big difference in how people in the Netherlands, not just care providers, felt about home birth. 5 years later, that study was shown to be flawed and not reliable. And to give the NRC credit, they did publish that. Oh, there it is. Oh, can't read the title? Well, that's because it was on page 8. And the conclusion was baby death is not higher in home births. Maybe too little, too late. This first study made all the difference. It reminds us that we live in this age. I think we're feeling this more and more, especially in the United States. Facts don't matter. I'm sorry, Jeannie, your answer was correct, but Kevin shouted his incorrect answer over yours, so he gets the points. Given the situation, how can we turn the tide? And here, I'm thinking about the Delta Works in the Netherlands. We all know that the Dutch are great engineers and great at controlling water, since so much of their country is actually under sea level. I think we need to create a Delta Works for physiological birth. And when you look at the Delta Works, you have to understand that there's the part above water, the superstructure, where the gates are, but that really relies on the part below water, the foundation. And so it is with thinking about how we might change maternity care. The superstructure is the way we organize care, but that rests on the foundation of culture. And if we're going to turn the tide, we need to pay attention to both. By culture, I mean specifically with maternity care, how does a culture think about birth? Is it risky? Are doctors heroes and saviors? What's the proper role for women and mothers? Is home a safe and clean place for birth? What's the balance between costs and care? Where's the line between how much we're willing to pay for quality care? What's the best way to make policy? Should we still be using the Polder model of negotiation? Do we trust nature or do we trust technology or some combination of the both? And all these things form the foundation of how we organize care. If we're going to create a Delta Works for midwives, for verloskundigen, I think we need to take a page from some work that was done earlier on the other side of life, not birth, but death. A colleague of mine from the University of Michigan, Roy Livney, has recently did a book-length study on rethinking death care in the United States. And this was what puzzled him as a sociologist, this sharp increase in the number of hospices and the number of people using hospice care at the end of life. And he asked the reasonable sociological question, how did this happen? And after years of research, he came to the conclusion that this was a carefully planned effort, trying to transform how clinicians, hospitals, and policymakers and the society thought about and approached death. And these are the things that he noticed occurring. This movement enlisted clinicians who would advocate for changing care, scholars who would study the topic, professors who would teach about the topic, professional associations of hospice and palliative care, organizations to educate communities, policy organizations to push policy change, and even artists and authors who wrote about and painted issues related to death. Basically, they were paying attention to culture and to politics. So if we're going to use this example to plan Delta Works for midwives, we need to pay attention to these four things: women, midwives, medicine, and politics. So let's start with women. We need to create a grassroots movement among women. We need to change the cultural message about birth. I suggest we begin a media campaign titled "Taking Charge of Life's Beginning," starting with a national symposium on the value of protecting physiologic birth, using new media and old media, community-based meetings organized by VSBs, which are cooperations between hospitals and midwifery practices. The message should be, physiological birth is not outer vets, old-fashioned. It's hip, it's healthy, it empowers you. It leads you to respect your choices and your community. We need to emphasize the value of choice as a way to resist the medicalization of life. And we need to emphasize that midwives are medical professionals, specialists in primary care. They're not medical assistants. If we want to create empowered midwives, we have to pay attention to their education. And my colleague, Dr. Suzanne Thompson, has a few things to say to us about this.
W.B. Yeats may or may not have said that education is not the filling of a pail, but the lighting of a fire. Thinking about overfull midwifery curricula, it may seem that midwifery education fills the pail. It's tempting to do this because there's always so many things that midwives need to know or to learn. I believe, however, that the lighting of a fire is much more important, particularly when educating midwives for the future. Midwives who are able to collaborate effectively with other professionals in all settings where women give birth, without losing the unique midwifery identity as advocates of healthy physiological childbirth. Midwifery education for the future should provide inspiring role models, establish a unique professional identity, build evidence-informed knowledge, and develop an agency for midwife advocacy. Providing students with role models, midwives, teachers who exemplify and embody midwifery professional identity is key. Role models are key to socializing and inspiring the next generation of midwives. The socialization of midwives is important. Early and regular exposure to healthy physiological childbirth supports students in internalizing midwifery identity as guardians of physiological childbirth. Evidence-based education that underpins the physiology of childbirth adds fuel to the fire, giving students vital knowledge for their burdening professional identity. Knowledge helps student midwives to feel powerful. And developing that power into agency, the ability to act to change the world around oneself. Couple this with persuasive communication, and you have a convincing communicator with fire in her belly. Midwifery education that turns out midwives who were able to meet the challenges of the 21st century in a spirit of equitable collaboration with other childbirth professionals, without losing the unique midwifery identity, is education that lights a fire and will inspire for future generations of midwives.
I like that idea of midwives with a fire in their belly. We also need to think about how can we create allies in the hospital among medical doctors. And I have some ideas about this. I'd like to see us, the Association of Dutch Obstetricians and Gynecologists and the Association of Midwives, create a Catharina Schrader Fellowship in Physiologic Birth, where recently graduated midwife and a recently graduated gynecologist would work together to do research on how to facilitate physiological birth and to reduce unneeded medicalization. Now, the point of this is to help identify and support models of integrated care, truly integrated care, that can protect and support physiologic birth. But it's also a way to get these two professions to come together and see that they're on the same team and they're headed for the same goal. I think this is a really important piece of policy, and I want to see this happen. Finally, we have to pay attention to politics, of course. We need to work at the national and local levels We need to work among cities, gemeente, among youth care, and with hospitals. And we need to emphasize at each of these levels the quality outcomes of physiologic birth, the cost associated with hospitals versus primary care births, the value of choice, the value of satisfaction. So these are my suggestions for how we can turn the tide and protect physiological birth in the Netherlands. To conclude, I just want to say, what have I learned among midwives? Well, I've learned, going back to what you said at the very beginning, the value of knowledge in science, the importance of how we organize care and how it affects the way birth is accomplished, and finally, paying attention to the heart, as Judith reminded us, and the need to honor the tradition of wisdom and presence that is midwifery. Thank you for being here. Thank you for the opportunity to be a professor. And I have just a few words of thanks to certain groups of people. First of all my colleagues at the Academie, thanks to you for putting up with me, coming and going, and all the support you've given me and all the great treats that were available there on the second floor. For the university, many people at the university helped me, but these two have been particularly significant in creating the chair and supporting the chair. And of course, at the Academy, these two people have been really crucial. These are the two people who hired me, these 10, 11 years ago. There are too many people at the Dutch Midwife Association to thank, so I just want to say thank you to the KNOV. And I also want to thank these gynecologist obstetricians who worked with me, most of whom are members of the Dutch Association of Obstetricians and Gynecologists. Most important, I want to thank these people, and these are my PhD students, most of whom have finished their PhDs, some are still working on them. I've learned so much from you. It's been so much fun to work with you all. And then some colleagues from the past. This is the Birth by Design group that I've worked with for many years. And of course, most importantly, the people who are willing to put up with my comings and goings. And that's my family. Thank you again. Ik heb gezegd.